Hello, everyone. Welcome to Spine Talks, where we bring unparalleled access to world-class experts, like the doctors who are joining me today. We're here to talk about osteoporosis and your bones, and I'm delighted to be joined by Dr. Bob Adler from Virginia Commonwealth University and the Richmond VA Center, and Dr. Paul Anderson from the University of Wisconsin. Before we get started, I'm going to invite each of these doctors to introduce themselves. Dr. Adler?
I'm Bob Adler, and I've been studying osteoporosis mostly in men for the last 30 years or so. And it's surprising to many that men have osteoporosis, but they do, and we can help them.
I'm Paul Anderson. I'm an orthopedic spine surgeon from the University of Wisconsin and have been dealing with research in osteoporosis for over 30 years, particularly as it affects the spine, and also have been in the bone health field for the last 15 years, leading programs to try to get people treated for osteoporosis to prevent fractures.
So we are here to talk about osteoporosis, and what's really exciting about this conversation is the interdisciplinary comments that we're going to have from Dr. Adler, who's an endocrinologist, and Dr. Anderson, who's a spine surgeon. So let's start off with talking about our bones. And as Dr. Adler said, people just don't know a lot about their bones, and they don't know a lot about osteoporosis. So I'm going to turn it over to Dr. Anderson to start a discussion about what are the bones in our body and why do they change?
Well, the bones are structure that allows vertical posture, locomotion, protect all of your organs, and is obviously essential for life. Most people think of bones once you're done growing as kind of an inert structure, but that's not true. Bones are constantly being formed, being broken down, or what we call remodeled. And as the remodeling gets a little bit out of balance, where we lose more bone on an annual basis than we put down, the bones become thinner or more brittle, and that can subsequently lead to fractures or changes in quality of life due to changes in posture, such as more bent over. And so trying to understand the physiology of our bones and that they're not inert structures but living organs that can be modified is important. And this ability to modify them through simple things like nutrition, exercise, supplements are things that people can do now. But once bones have lost too much, then we begin to think about medical treatments for them.
Yeah, Dr. Anderson, thank you so much for sharing that idea that people really don't think of bones as an organ that changes. You know, we see our muscles can change and get bigger or smaller. We can feel our heart beating. We know that that's going, but we can't really see our bones changing. And so, you know, after we're done growing, we sort of think the bones are done. But that's really far from the case at all. Dr. Adler, as an endocrinologist, you see patients that come to you with bone disease. And explain to our audience what that's like when you are explaining to patients what's happening with their bones.
Well, what I tell them is that I'm an older man, and if I should fall and break a bone, that's basically what osteoporosis is. That is, my bones aren't strong enough to withstand the force of the fall. And as we get older, falling becomes more common, and our ability to live through that fall without injury decreases. And part of it is due to the fact that all of us, over time, gradually lose bone and get to a point where we will break should we have a fall. So one of our ways of avoiding fracture is to avoid falls. And so when we have a conversation about osteoporosis, it includes things like home safety, exercise to improve balance and strength, nutrition to improve the same. And that's part of our management. So it isn't just medications, it's an overall comprehensive program for bone health.
And we've talked about some really important things here. There are things that people can do to maintain the health of their bones. Diet, calcium, vitamin D, we talk about that a lot. Eating foods that are rich in those sources. Weight-bearing exercise, because we know that weight-bearing exercise helps build those bones. But for some people, nutrition and exercise alone is not enough to maintain their bone health. And that's when they have a disease of their bone. And Dr. Anderson, you've helped me understand that thinking about osteoporosis is analogous to thinking about something like high blood pressure, where it's a chronic condition that needs ongoing treatment for life. It's not just a one and done situation where you treat the bone in a moment, but it's an ongoing level of treatment that has to happen. Dr. Anderson, you see patients with spine conditions. Dr. Adler, you see patients with bone problems throughout their bodies. Let's talk a little bit about bone disease in the spine and how people might know that they have it or how it can get missed. I'll start with you, Dr. Anderson.
Well, unfortunately, osteoporosis is a silent disease until it's not silent, and that means until it breaks. And so osteoporosis is significantly under-recognized in patients because you can have severe osteoporosis, never know it until you lift something up or have a ground-level fall, and now you're in the hospital with a broken hip. So you have to understand that it's very hard to pick that up, but we do have screening criteria to aid your physicians, practitioners in deciding when to undergo specific testing to see if you have osteoporosis. And the standard test, it's not the only one, but it's the standard one, is something called a bone density test, or also called a DEXA scan, DEXA. And this is very sensitive, low radiation, fairly low cost test. But not everybody needs one, but there are certain people with risk factors, and many of the risk factors are pretty obvious, like family history where your parents have had hip fractures. If you're over 65 in female, over age and 70 in male, if you have certain endocrinology diseases, these are things like diabetes, for instance, which is obviously very common, but also hyperthyroidism, hyperparathyroidism, chronic renal conditions. And there's other list of risk factors, medications. If you've been on steroids, even intermittently, you're probably at high risk and should have some type of screening test.
And so, Dr. Adler, let's talk a little bit about this interdisciplinary moment that happens where a patient goes to see their spine surgeon. The spine surgeon is doing some preoperative bone screening. They detect that there is a need for bone optimization. And Dr. Anderson says, your DEXA scan has revealed that your bone quality needs treatment before I operate on you. I want you to go see my friend Dr. Adler and talk about this.
Well, the first thing we do is a good history and physical exam. It turns out that secondary causes of osteoporosis are common in men, and the history and physical examination often reveals just what that secondary condition might be. And many of them are quite treatable and can improve bone and improve fracture risk just by treating the underlying disease. So we do a comprehensive exam, some laboratory tests, not a lot, but some laboratory tests, and they're usually targeted. That is, the astute clinician is able to figure out, usually from the history and physical exam, what tests to do, and then we can treat that. I'd also like to mention that genes clearly play a role. As Dr. Anderson mentioned, having a family history of osteoporosis is really important. And so even if you do all the good things, that is, you get adequate calcium and protein in your diet, and your vitamin D is fine, and you're exercising, and you're doing all the right things, your genes clearly play a role, as they do in so many other diseases. And so don't feel bad if you have osteoporosis or you fracture. It's not your fault. even if you've done all those things. And fortunately, we have ways to treat underlying disorders and also to treat osteoporosis itself. Making the diagnosis is important because then we can get a treatment program that's likely to reduce your subsequent fracture risk.
Making the diagnosis. I think that's one of the challenges that often faces doctors, whether they're surgeons or primary care doctors, and for patients to understand. And it feels a little bit frustrating because we have the tools to find this disease. Dr. Anderson, you have been in leadership roles in many organizations, including recently with the ISCD organization, which oversees diagnostic tools like the DEXA scan. Can you talk with us a little bit about diagnosing osteoporosis?
The diagnosis, first of all, does not always require a test. If you have a ground level fall, if fracture your spine or your hips, by definition, as Dr. Adler alluded to, you have osteoporosis. You don't need a confirmatory test.
And Dr. Anderson, explain to us, what is a ground level fall?
That means a low energy fall where you tripped and while you were standing up and fell. You may have fallen out of bed. This is a common thing. And you tripped going to the bathroom is a real common scenario. For the spine, we oftentimes see people bending over, picking something up out of their trunk, and they start having back pain. They take an x-ray. Now there's a fracture, so it's not even a fall. This is a lifting accident. Or sometimes they just occur spontaneously. Nobody even can identify a cause. So any of these low energy trauma, and I'm not necessarily talking about you fell off your roof and broke a bunch of vertebrae in your spine, but these are low energy traumas. Now, on the other hand, there are patients who haven't had fractures yet who have osteoporosis and maybe require medical therapy. Screening those is problematic because they're under-screened right now. We do have tests, like I mentioned before. The DEXA test is an excellent test at screening for those patients, but somebody has to order it and it has to be interpreted properly. Many times it's poorly done, unfortunately, and errors are made, so it's always worth going over with your physicians what the results mean of that particular test. Dr. Adler, it's obvious that if your mother had a hip fracture, your grandmother had a hip fracture, that as a daughter, you're at high risk for having a hip fracture. That seems very intuitive to me. But what about on the male side? If your mother had a hip fracture and you're a male, are you at increased risk for hip fracture?
We think so. We think that parental hip fracture is really a risk factor. But there's a nuance that's actually quite interesting, and that is if your parent had a hip fracture at age 80 or less, you're at much higher risk for a fracture yourself than if they had it much later in life. So it's like heart disease. If your parent had early heart disease, had a myocardial infarction in their 60s, let's say, you're at higher risk for one yourself than if they had it at age 89. And so it's a very interesting analogy with heart disease. So if there's early fracture in the family, that's a particular import. But it works for men as it does for women.
Osteoporosis in men, that's an area that you have studied extensively and written about in the scientific literature. It's an area that I think there is a lot of myth and misunderstanding amongst the public that osteoporosis is a women's disease.
Yeah. So in young men, there are actually more fractures in younger men than there are in younger women, but they're traumatic fractures, and they're supposedly due to risky behavior. As far as osteoporotic fractures are concerned, men lag behind women by about 10 years. So that we do see some spine fractures in middle-aged men, and then the hip fracture is seen in men in their 80s and beyond. But think about this. The baby boomers are getting close to 80. So we're going to see a lot of fractures in this older cohort of people that are aging, many of them doing well, going from no fracture to fracture changes the life of men, particularly, very dramatically.
So, Dr. Adler, are you saying that life expectancy, if you will, of a man who fractures a hip is worse than it is for women who fracture a hip?
Yes. The death rate 1 year after a hip fracture is twice in men compared to women. And men do worse after spine fracture as well compared to women. And it's not just the death rate, it's the loss of independence. And I think men are particularly affected by that loss of independence that happens after a fracture. They go from doing everything, being independent, able to do anything, being a leader, to bedbound for a while, gradually getting their mobility back. And it's very difficult for them to deal with that. And so I think that's part of the problem. So it's not just death rate, which is significant, but it's also the loss of independence.
That's what we're here to talk about today, is that it doesn't have to be that way. We have tools. We have a big war chest to fight this disease.
In men, as Dr. Adler said, they have a higher mortality rate. And from my just experience as a surgeon, orthopedic surgeon, is a man who sustains a hip fracture has a lot more medically going on. They oftentimes have early cognitive impairments, be it some form of memory loss. There's undiagnosed Parkinson's disease, maybe in 80-year-old men or older who fall and break their hip. Somewhere around 8 to 10% may have some form of Parkinsonism. Another study that's of interest to spine surgeons is many patients, men with hip fractures, have cervical spinal cord compression. And what I mean is your spinal cord in your neck is pinched, and that one of the early milder manifestations leads to gait instability, and so it makes you more likely to fall. And this will be not diagnosed unless somebody is really looking for it. But also they tend to be sicker, a lot more comorbidities such as heart disease that leads to that higher mortality. And also their outcomes, as we mentioned, the quality of life is never the same. They're not able to, they may have been independently been able to care for their house. They can't do that anymore. They really see a diminution of their quality of life. And this can lead to things like depression. We don't usually think of older people having depression, but certainly a fracture with loss of independence is a highly toxic combination for people psychologically. Mm-hmm. If you asked people over 80 what's their biggest fear, one of their biggest fears is, I lose my independence, I have to go to a nursing home.
Right.
They would rather die in most cases than do that. Yeah. And so people need to understand that we have tools. You can diagnose the problem and get you on this multifaceted treatment. It may or may not include medications. We could try to maintain that independence, and it works just about as well in men as it does in women. All of these medications, for instance, with one exception that's not approved for men yet, but work quite well in men as women. But somebody has to step up, get this diagnosed, hopefully for fractures.
Yeah. Well, so what I'm hearing is there's good news. There's good news in osteoporosis because there is a lot of confusion around getting it diagnosed and helping the patients get to the treatment. We want people to understand that they should ask those questions for themselves. Part of what we're doing here today is encouraging individuals, you who are watching this, to talk to your doctor about your bone health, because sometimes you have to be your own best advocate in pushing that conversation with the providers who are in your life. Let's talk a little bit about treatment. We know from surveys that we've done from patient audiences that people are confused a little bit about the treatments, and there's some fear about being treated for osteoporosis. We've talked today about what happens if you don't get the osteoporosis corrected? And that is a bad outcome, loss of independence, and possibly even earlier death. We know we can't live forever, but we want to live well as long as we can. And the osteoporosis treatments allow us to do that. So Dr. Adler, I'll start with you. Talk about treating osteoporosis and help the public understand if there's fear or concern about side effects.
Well, with every medication that we use, we always think about risks and benefits because there are no medicines that don't have risks. It is said that if the FDA had to approve aspirin today, it might not make it because it has risks. And yet people think because it's over the counter that it is risk-free. Well, that's not true. So every single medicine has benefits and risks. And the clinician is going to think about that when ordering a medication for osteoporosis. So the osteoporosis medications fall into two categories. One is the anti-resorptive category. What this does is it turns off the osteoclasts, which are the cells that are constantly gobbling up some bone, and it slows them down so that the osteoblasts, the cells that make bone, can catch up. The other medications are so-called osteoanabolic drugs, which actually stimulate those osteoblasts to make new bone. So depending on the particular patient, we might use either one or we might use them in sequence, depending on a lot of factors, including cost and ease of use and the like. Most people get treated with the anti-resorptive drugs. They're inexpensive. They've been around for 30 years. They're FDA approved for men as they are for women. They work just about as well in men as they do in women. And what they do is decrease the risk for a fracture so that if you fall, you are less likely to fracture. In most cases, people don't feel any different on the medication. They don't notice any difference, which is sometimes a problem in continuing to take the medication. You know, if you stop your insulin, you'll know that you don't feel well.
Right.
That's not the case with osteoporosis medications. You're not going to feel any different whether you take it or not. And so it's really important that you continue to take it properly. And as I said, what these meds do is decrease the risk of fracture should you fall or should you try to lift something that you shouldn't be lifting. And for most people, there are no side effects. The chance of the more serious side effects are similar to the chance of being struck by lightning. Not zero, but pretty uncommon. And one of them is called osteonecrosis of the jaw, and there's a lot on the internet about this. Your jaw does not fall off. But if you have a tooth pulled, there may be trouble with healing. So those people who take good care of their teeth, go to the dentist regularly, and do all the things that to try to maintain their teeth are less likely to have that. The other one that causes a lot of concern, again, a lot of information and disinformation and misinformation on the internet, are the so-called atypical fractures of the femur. And this is seen mostly in people who've been on the anti-resorptive drugs for a long time. And so they can be avoided, we think, by careful follow-up and stopping the medications at times after an initial course. Our sequence of the medications may play a role. We have more to learn about this, but again, the chances are low. And so if you're about to start one of these medications, it's really important to know that the chance of your preventing an osteoporotic fracture is much, 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 much greater than the chance of your having one of these serious side effects. So we save lives, we save fractures by treating patients for osteoporosis.
The anti-resorptives, what are some of those medicines that people would have heard?
So those are the bisphosphonates mostly. They're the ones that have been around the longest. So alendronate, risedronate, and intravenous zoledronic acid. I'm sorry for that name. That sounds awful. But it's been around a long time, and it's generally very well tolerated. These medicines, again, work by turning off the osteoclasts. The oral ones are taken usually once a week. The intravenous is taken yearly, or in, some people like me will treat people every year and a half or so. And there's a very interesting study in women that just came out that showed if you get one infusion of that medication and then are followed for 10 years, that one infusion lowers the fracture risk. So it's an amazing improvement in fracture risk just from one treatment. So it really is important to think about this. And in that study, there were no significant side effects. So people tend to focus on the downside, and what they should be focusing on is prevention of the downside of getting a hip fracture or spine fracture or another kind of osteoporotic fracture.
Do the medicines work the same in men as they do in women?
As far as we know, the medicines work the same in men as in women. The response is very similar. But, you really can't compare them because they're not exactly the same population. They may not have the exact same risk. As a matter of fact, when we study drug A in one set of women and drug B in another set of women, you really can't make an exact comparison. You can get some idea of the relative effectiveness of the drug, but it's not exactly the same because it's not exactly the same population. Right. So in general, though, the medications work the same in men as in women.
We've been talking mostly about these drugs that are safe for the most part, have been out for a long time, have really good history. The anti-resorptives, what are some of the names of some of those that patients would know the names of those?
Well, the brand names?
Yeah.
Well, the Fosamax was the one that was the alendronate. Actonel was risedronate and reclassed zoledronic acid. Mm-hmm. Another one that we tend to use less is ibandronate or Boniva. And all of these medications are FDA approved for women, and all but ibandronate, Boniva, are FDA approved for men.
People see those ads on TV or understand the names, and they're anti-resorptives.
The other anti-resorptive that I haven't talked about is denosumab or Prolia. Denosumab also turns off those osteoclasts, but it works in a somewhat different way. It's very convenient because it's a subcutaneous injection given every 6 months. So it doesn't increase pill burden, and it's very nice that way. It's generally very well tolerated. But just like with bisphosphonates, there have been these unusual serious side effects, but they're not very common. They're uncommon. And so, again, we're not concerned about them very much. Of course, we talk to our patients about that.
So the anti-resorptives, so that's one kind of medicine. Anabolics are a different kind of medicine. Those are the bone builders. Anabolics are very, very important for patients who need to have surgery.
Well, the anabolic drugs are going to speed up the improvement in your fracture risk. In other words, how much these drugs reduce fractures. They also increase your bone density faster and to a greater degree than the anti-resorptive drugs. On the other hand, they're much more expensive. 2 of the 3 of them require daily injections. The other one is a monthly injection. But their big burden is their costs. And obviously it depends a bit on the type of insurance you have, how things are in your region, what is covered in your region, what isn't. So there are those downsides. But those drugs are particularly useful if we're trying to get somebody who has osteoporosis and is going to have spine surgery to try to reduce complications associated with osteoporosis when we do spine surgery. For instance, the typical thing we do in spine surgery is a fusion, and that involves putting screws in the bone. If the bone is really brittle and soft from osteoporosis, naturally those screws don't hold. It's a bit like putting screws in a plaster wall versus your 2x4s. And we'd like to put them in 2x4s. And so towards that end, we would like in osteoporotic patients who are at risk for these screws failing, we would like to treat them before surgery. We don't want to delay that surgery for years, so we'd like to speed that up. And that's where the anabolic drugs particularly are useful. And this, again, this whole concept works both in men and women. I would say that in men, we typically are going to use drugs, the trade names are Forteo and Tymlos, and there's a third drug called romosozumab, and that's just not approved for men, although we will occasionally use it in what we call off-label use. But typically we're going to use the Tymlos and Forteo for a male who is about to undergo surgery.
This is such an important topic because osteoporosis is at epidemic levels. We just don't talk about it enough in our world. Today has been so useful in kind of giving this overview of who gets osteoporosis, why they get osteoporosis, and what to do about it. And I'm so grateful that Dr. Adler and Dr. Anderson are here to say that there is good news. This is a disease that we can detect. This is a disease that we can treat, and that treatment is going to give better years, potentially longer.
So a man at age 50 has about a 1 in 5 or 1 in 6 chance of having an osteoporotic fracture before he dies. So it's pretty darn common. And I don't think men think about that at all. And yet it happens a lot. And again, men do worse after a fracture than women. So we need to pay a lot more attention to men because we have lots of ways to help them, lots of non-pharmacologic ways and pharmacologic ways. And we can help. And most of the time, we can make things better and decrease the risk for fracture.
One of the impediments to men receiving care is the stigma that they have a disease that's traditionally kind of considered a female disease. Yeah. How do you explain that to men that you're going to treat to overcome that stigma?
We used to have classes for osteoporosis for men, and it was really important that men saw they weren't the only one. We have a busy clinic of veterans who have osteoporosis, and for many years it was mostly men. We have a lot more women now. But I think it was important for men to realize they're not alone. They're not a oddball. And that's why I think it's important for them to know just how common it is. And as a matter of fact, in a given year, an older man has a higher chance of having a fracture than he does of having a heart attack or having a new diagnosis of prostate cancer. So I think getting across the message that osteoporosis is really quite common in men may help in overcoming that stigma of this is just a lady's disease.
What is your risk of mortality of a male with a hip fracture versus a male with a new diagnosis of prostate cancer or even myocardial infarction, which is worse?
Well, I was talking to a medical resident recently, and I told her that for a man between the ages of 75 and 84, kind of the prime area for hip fracture, the chance of dying within a year of that hip fracture is 1 out of 3. And I asked her to tell me what other diseases she deals with that have that kind of mortality rate. And they're not a lot.
No.
So hip fracture is a major killer in men, and that's why we really do need to recognize it.
Yeah.
I mean, the only diseases I can think of is brain tumor like glioblastoma,
Yeah.
and maybe stage 4 pancreatic cancer, stage
Right.
4 lung cancer. But the only diseases that have the mortality that an osteoporotic hip fracture does.
Right. Yeah.
There are very many diseases like that, and
That's
it's
exactly
unfortunate that it is so under-recognized and undertreated.
Yeah.
And we have the treatment. We have the tools to treat it.
We do.
So we don't have to have those numbers. And Dr. Adler, you do a lot of work in the Veterans Administration.
Yeah.
Can you tell us about the veterans out there? What kinds of things can they be doing?
They can be like anyone else. That is getting adequate calcium and protein in their diet, getting enough vitamin D. Usually need supplements for that. It's not easy to get it in the diet. Stopping smoking if they smoke. We don't know why, but smoking is clearly a risk factor for fracture. Staying in good physical shape, taking care of their teeth, all of those things that all of us can do. Ben Franklin said an ounce of prevention is worth a pound of cure, and he was absolutely right. And it's really true for osteoporosis. So there's some things that everybody can do, every man can do, every woman can do, and that helps. That decreases fracture risk, but in many cases it's not enough. So asking your clinician, am I at risk for osteoporosis, I think is really important because a DEXA test is risk-free, relatively inexpensive, although reimbursement is sometimes a problem. Of course, we don't have that problem in the VA, but it really is important that men get that. And at what age, it's not clear, but certainly in older men, it should be done. And those who have risk factors, it should be done for sure. And then we can treat it. And so I think it's really important to make that diagnosis.
I'd say as a spine surgeon taking care of many older men who fell off ladders, is that people over the age, and I don't know the youngest age, but 65 or 70, should not be on ladders. And if I can give any advice to the wives or the children of a senior male, take the ladders away and turn them in. There was one program at the fire department was having turning your guns. This one was turning your ladders. and I can just tell you it's heartbreaking to see a very active, cognitively normal male fall off a ladder and die. Of a broken neck or a broken back or soluble lung injury. And so men should, one of the behaviors they should not do as they get older is get on ladders or even step stools. It's just too dangerous. You don't have the balance you used to have. You don't have the muscle strength that you used to have.
The effect of hormones on our bone health is something that we hear a lot about, and it's a big topic. For today's conversation, where we're talking about osteoporosis in men especially, but also just in the general population, Dr. Adler, can you say a few words to our audience about the effect of hormones and maybe the difference between testosterone for men, estrogen for women, as it relates to bone health?
Yeah. Well, there's no question that the loss of estrogen at menopause is a major risk factor for fracture in women. And this is probably why women fracture earlier than men. There are some other reasons, but that's a major one. With men, there's no dramatic drop of testosterone over time, but it's a gradual drop, and it's in parallel to the changes in bone and muscle that happen with aging. The studies show that testosterone replacement for those men who truly have testosterone deficiency due to a pituitary problem or a testicular problem, that increases bone density and increases muscle and probably decreases fracture, but it really hasn't been proven. In a lot of older men with mildly lower testosterone with aging, the guidelines say if they have symptoms of low testosterone, treat that. But that may or may not have any impact on bone. If they have osteoporosis, use an osteoporosis-specific drug because those drugs have been shown to decrease fracture.
Adler, as we're talking about the effects of testosterone on men's bone health, prostate cancer is very prevalent.
Prostate cancer itself probably doesn't have much effect on bone, although the cancer can go to bone and cause a lot of problems. But for other men, prostate cancer is treated with hormone therapy. And the hormone therapy lowers the testosterone to close to zero. And it turns out those men are at high risk for fracture. In some studies, the fracture risk is as high as 15% in 5 years. So the hormone therapy works well for survival of the prostate cancer patient, but it puts the man at risk for fracture. So those men need to be assessed. They need to have a bone density. They need to see someone who's an expert in osteoporosis because we have very good medications that work quite well and lower the fracture risk in that particular group of men.
This has been a fantastic conversation. We're so grateful to Dr. Adler and Dr. Anderson for giving us their time today. I'm going to close now by asking both of these experts to give us some closing comments. And I'll start with Dr. Anderson.
Yeah, I would say what's important for patients is to know your bones. And really what that means is ask your primary care physician or practitioner, am I a candidate to have my bone density measured? Am I at risk for fractures? And ask those questions. You could also read material that is on the Spine Health Foundation's website about these topics. There's a lot of material aimed for patients to help them assess their own bones.
Most of us older people know someone who's having a good retirement, and then they fracture. And that's the end of the good retirement. We all want to have a healthy life after our work is done. And one of the things that really ruins it is a fracture, and it can be prevented. So act.
I want to thank Dr. Adler and Dr. Anderson again for their time today. This has been a very helpful and actionable conversation where we are inviting you to advocate for yourself, for your health, and for your bone health. We cannot do the work that we do at the National Spine Health Foundation without the volunteerism and the commitment of the experts who join us. We call these experts healthcare heroes. Dr. Adler and Dr. Anderson, you are our heroes. You go to work every single day to help people live their best lives. And we thank you for that. We thank you for contributing to the body of educational content that is free and available to everybody. Thank you for joining us.